thing started.
Okay.
Or I can push record. Oh, no, yeah, it'll go on my, no, you gotta push it because otherwise it'll go on my computer and when I have to get off, it won't be
That's okay.
recorded.
I pushed record.
Okay. Okay, terrific. Welcome, everybody. This is Patty DeGangi wishing you all a happy new year. I want to let you guys know if you hear sounds in the background, it's because I am at the airport. Patty, go ahead and change the slide. I'm trying to get the slide to change. I'm literally at the airport. I thought I had an 8:25 this morning, a flight, and I had an 8:25 tonight. Although I've been delayed to 9:45, so I may be able to be on the whole meeting, or I may not. But we've got it set up. Patty Beeson is running the technology. Kathy Forbes is ready to take over. And also we have other people that already said they're going to help out. So thank you, everybody. Go ahead, Patty. So again, Jill, Noelle, Patty, Kathy, Linda, and Paige. Paige is not here tonight because she is in India. It's really been interesting watching her journey. Go ahead, Patty. This reminds me of the old film strips back in our old days.
Yeah, exactly.
So we're going to be on 90 minutes tonight, maybe less. I mean, it depends on how much we discuss things. I hope that you each, go ahead, Patty, got an opportunity to download the, Patty goes 2 slides ahead and then we'll go back.
Okay.
To download, go ahead to the one where it says, yeah.
No, that one back.
Nope, back one. Okay. To download what are the things we're going to discuss tonight. If you haven't yet, look in the chat box. In the chat box, if you go all the way to the top of the chat box, I put in the link there so you can link to the WeTransfer and download, because you probably find it that it's easier if it's in front of you, because we'll switch back and forth and it just might be easier. Okay, now go back to let's talk about who's here. So I want to welcome everybody again. I'm going to go through this as we have before because I just love hearing your voice, because I know I want to hear that you're here. So once I say your name, just say hi, hello, happy new year, whatever you want. If you're not listed here because, like, I see E, you didn't sign up, you didn't tell me you were coming, but that's great. We welcome everybody and we're glad you're here. So let's get going. Is Angela here yet? No. Anne Marie, why don't you say hi while you still have a voice?
Hi, Jim Marie. Happy New Year, everybody. Got a slight voice.
So Barb is not going to be here. She thought she was going to be able to hear with Barb. Right, because isn't going to be here with Barbie. I think I see you here.
I'm here. Happy New Year.
Happy New Year to you. Beth, are you here? Not yet. Carol Roselle? Because sometimes people are also on the phone and I can't see that. So Carol Roselle? Not yet. Kathy Stewart? Cheryl? Cheryl? I know you're here because you were the very first one that signed on. I don't see you might still have yourself muted. Patty, we have everybody muted. Did you do that?
Muted.
No, it's off again. Maybe you need to do it. Unmute.
Unmuted.
Hello?
Okay, there we go. Okay.
Okay.
Cheryl? No, I know Cheryl's here. Anyway, Connie. Connie Simmons. I see you there, Connie. Say hi, Connie.
Hi,
all right, keep it going.
I'm here.
There we go. There we go. There we go. There we go. Alicia.
Hi, everybody.
There we go. Thrilled you're going to be here. Alicia, I'm going to call on you at one point when we talk about one of the proposals that I know you're on our committee for and work so hard on. So thank you. Evelyn, is Evelyn here yet?
I'm here.
Hey, there you are. I also see Dana Myers. You're here, but I don't see, you didn't come up on the list. So say hi, Dana.
Hello.
Hello. Jamie Collins. Jamie? Oh, well, she's here. Janet Jordan.
I'm here.
Terrific, thank you. As always, Jean.
I'm here.
Jennifer, thanks, Jean. Jennifer?
Hello.
Great that you're here. Jill you're back again, I see. Say hi, Jill.
Hi.
Thank you. Kendra,
Hello.
next.
Happy
Great
Sunday.
to see you. How's your website going? Never mind, we can talk about that later. Okay,
going.
next slide, Patty.
It won't move.
Next slide, Patty.
It won't move.
Oh.
Oh, I love
have-
technology. Hold on.
Sometimes we go to meeting windows open and it'll be a little stubborn.
Okay, let's try it again. There we go.
Okay, there we go. Catherine. Not yet.
I'm
Chris
here.
Potts.
How are you?
Oh, you are. Oh, terrific. Terrific. Thank you. Chris Potts.
Everybody.
I don't see Chris yet. Lucy.
I'm here. Hello.
There she is. Thank you, Lucy. Linda Jorgensen.
Hi, everybody. I'm here.
And Linda, when I get to that section where we're going to talk about what you and I talked about on the forum, I'm going to talk about it in a couple places, but I'm going to actually hand the microphone over to you to explain because you do such a great job at it. So thank you.
Okay, I'll press
Michelle.
on.
Michelle.
Hello, this
Michelle
is Michelle Gross-Pinko. Happy New Year.
There she is. Natalie is signed up, but I don't know that. I thought Natalie was leaving the country, so not for good, just for a trip. Noelle, I know you're here, so say hi.
Hi, everybody.
Betty Beeson, of course, she's running our technology.
Uh-huh.
I happily so too. Renee. No, I don't see Renee yet. Sandy Rago. I think Sandy I just saw. Sandy?
I'm here.
Still
I'm
trying to
just
get on.
keeping myself muted.
There we go. Susie Brzezinski. Say hi, Susie. Susie.
I saw her on there.
I see her, yeah. Nice anticipation there, Tammy. Tammy, President, immediate
Hi,
past
Patty. I'm
president.
here.
We're thrilled that you're here, Tammy. We have some great stuff to talk about, maybe some suggestions for a PR or whatever form we might need to go to ADHA's house, but we'll get there. Tasha, I know I saw you.
I'm here.
Terrific. I'm looking forward to seeing you in a week. Not even less than a week now. Yeah. Teresa Shepard, I saw you come and go. You, Teresa? I know she's here. I see her. Tiffany, say hi, Tiffany. Tiffany? I'm not getting anything through. How about you, Vicky? Say hi, Vicky.
Hi, everyone.
And is there anybody else that I haven't recognized that is here?
Kathy Forbes is trying to get in.
I am in now.
You are
We're
happy.
really glad.
Okay.
We're really glad Kathy Forbes is trying to get in.
Yes.
Anybody else?
Is here.
Who?
Lisa Funk.
Hi, Lisa. Welcome. Welcome.
Hi.
Welcome. And E, you were here. Edward was here, but I don't see him here anymore. I don't know. Anyway, all right. What I'm gonna do is, Jamie, I have Noelle that's going to count votes in the chat box, but if you could just watch for other comments in the chat box, because again, we've got a lot to talk about tonight, and you can help with managing it, that would be great. Patty, you're just going to do slides, okay?
Yep.
So next slide, Patty. In a newsletter, I announced that on the 14th of January, which is a week from tomorrow, Susan Ringo is going to help us lead the mastermind. In the newsletter, it said Sunday, but it's actually Monday at 8 p.m. Central Time. I'm excited to talk about what she's going to discuss, along with not just the information elimination, but the coding for it. So that's for everybody. Please, the e-bite will go out probably on Tuesday. It does help when we do the e-voice if you do respond. So next slide. Again, if you haven't downloaded the proposals that we're going to talk tonight, then that address, that really monstrous address, is in the chat box. Go all the way to the top. I put it in there in the beginning. Next slide. Masterminds are a think tank. I do want to let you know, if you didn't hear it already, that Sandra Berger, one of our insiders, Dental Codology Insiders, has been providing through her AGD certification the CE for the last couple of months. She also, though, helped Dental Codology, and now we officially have our PACE AGD certification. Next slide. We also have changed the name from the Dental Codologist membership to Dental Codology Insiders. We've got a new website it's supposed to be up tomorrow, she says with hope in her voice. And there will be some renewal notices and some other things, many things changing, all with lots more benefits for all of you, particularly having a place that you can go for information and anytime you have a question, anything and all things coding. Kendra, matter of fact, Kendra and I were working on Candy, here I go, I'm going to tell everybody, on a concept that to shift our thinking, rather than thinking about dental coding or medical coding, but starting to think in the realm of medically necessary coding. Because anything that's done in the oral health world is connected to the rest of the body. We all know that, right? Well, that's why it's like sometimes we need to change our language to change our thinking. So it's medically necessary coding. You'll hear more about that as we move forward. Next slide. Now, one of the goals of this group is, and always has been from the beginning, for us to get a seat for someone of this group, other than most everybody that's on the coding committee at this time are from a dentist organization, and it is our goal to have ADHA and the assistants and as many groups, other groups as possible, to have a seat at that table. Our vote is our voice, and we have other ways to have our voice heard, and we're certainly going to talk about that this evening. What we're going to do, and what we've done in the previous years, is there are 146 submissions that were made to the coding committee that will be voted on in March. We are also going to vote on them, and the reason is that we want to learn to behave as if. We think, well, you know, an awful lot of us are hygienists, although this group is not limited to anybody, a dentist, an assistant, office managers, anybody is welcome to be part of this group. But the thing is that we don't know about those things. Well, you know what? We need to behave as if. So that's what this concept is about. We're going to behave as if we're on that committee, and if we're on that committee, we would be voting on 146 of them. We're not talking about all of them tonight, though. Just saying. Moving forward. To keep us centered, it's always like, you know, I don't give her enough credit, but Jill, the wonderful Jill Grassman, is the one that takes what is these crazy phone calls. Yeah, the crazy phone calls that we have to plan these things and puts them into an agenda that I'm able to then take and put it into something else. This is absolutely a teamwork process. So thank you, Jill, for keeping us centered, on what we do at these meetings. So next slide. Yay! One of the things is really important is if many bodies as we can have come and attend the code meeting here in the Chicago area, is actually the ADA headquarters, the more strength that we have. It is a 2-day meeting, and in the last couple of years, I've got it all the work done in 1 year. Well, those of us looking at it now going, oh, I think it's going to go back to the 2-day meeting. But it's on Thursday, Friday, March the 14th and 15th. Now, just an interesting turn of events is I think it's on the 13th or something like that, is the Camber Commission is also meeting in Chicago. And right after that, ADEA, the American Dental Education Association, is meeting here in Chicago right after that. So it should be an interesting year as to who shows up and what kind of testimony that we hear at that meeting. But if you want to plan ahead and you know, get your reservations for, somebody said they can't hear me any longer. Patty, can you hear me?
I can hear you.
Okay. Anyway, so if you want to get there, okay, people can hear me. All right. That's the dates. And we'll eventually do a sign up. People are saying they have no audio either. I have no idea what happened.
You were kind of going in and out, so.
I can hear you, Patty. This is Evelyn. I can hear you.
Okay.
Okay. Okay, what I'm going to do is when somebody else I give over the microphone, I'm going to switch from the headset to going on. I'll do a call in. Hopefully that we can hear better.
Okay.
So, Patty, next slide. We have a lot to discuss, and there is 146 code actions. It's an elephant. Patty, next slide. That's why we need to prepare. This is the schedule that we have created, because in order to go over 146 of them, we've got to divide them up. So our next meeting is on the 20th, and then you can see the schedule after that. This schedule will be posted on the Democodology website, and I will send it to each of you so that you can get it on your calendar. You want to take a screenshot now? Go for it. That's the schedule that we have set up for in advance. Go ahead, Patty. Again, how to eat an elephant one bite at a time. Go ahead, Patty.
Linda.
And this is where Linda did some amazing work. He took these 146 categories and grouped them. Now, in previous years, having spent a lot of time working with this committee, the way the committee had worked before is they were almost organized that way for us. They were not this time. So it took quite a deal of time. So again, ovations to Linda for taking these and grouping these. The ones we're going to talk about tonight are the ones in yellow, and how we're going to speak up and talk about each of them will be deciding as we go. But thanks again to Linda for doing all that work.
Welcome.
Next slide. Now, in front of you, that again, I hope you have, each of you have your, we really have, 10 questions that we put together that are for you to think about when we're looking at these submissions. Some of them are related. Are there related submissions? Now, we're going to be grouping them in related submissions, but it's something in general. Are they related? How are they related? Are they a duplicate of a code that's already there? That happens because, see, anybody, as we've talked about on this group many times, is that anybody can submit a code. And sometimes people don't know that a code already exists. So it could be a duplicate. Is the submission product-based? Codes are not for products. Codes are for procedures. They are not insurance codes. They're not product codes. They are procedure codes. So that's another thing. Is the submission clear? We have one especially that we're going to look at tonight going, wow, that's really questionable. The next is who submitted it. Now, this is where the beginning and some aspects of politics come in, because the who of the submission and who they have with them does and can make a difference. Next slide. Is the submission unbundling? Now, I'm going to put a definition on the screen later in the time that we have here today about what unbundling is. But it has been the tradition of the Codes Committee to not want unbundling. Let me explain it this way. Unbundling is if somebody's having a crown, they don't think there should be a procedure for the temporary, for the anesthesia, for this, for that. So that's really, I'm going to talk about that a little bit more later. Is it product neutral? Again, it's pretty much the same product thing I just talked about. Is it procedure specific? Is it clear? Is it provider neutral? And that's a really, really important thing to many of us on this call. That is this provider neutral? Next slide. Does the proposal's language does not impose any specific business model onto the procedure described? So this is where I am going to hand this over to, next slide, to Linda, because this is something Linda's been thinking about working on and has really down on what that means. And I think it's a really, really important point for us to consider. And again, I'm going to switch over to my phone while this is going on.
Okay, hi everyone. Hope you can hear me okay. Thank you for putting up this that image. It's the back-to-back sheet that we kind of developed about our goals, our vision, mission, and goal statement. And specifically, I called Patty a couple of days ago and I said, I feel like we should take our goal number 2 and fill it out a little bit more, because I think we know what we meant when we said that we thought that the CDT manual should foster consistency. Well, that the wording should be consistent and fair in the nomenclature and descriptors. And so, we talked quite a bit about ways that we think it's not consistent and not fair. And it had to do with those things that Patty just discussed, including product neutrality, business model neutrality, and provider neutrality. And then, of course, maybe based on evidence, scientific evidence, but we have that in our core value. But when we're talking about these, the codes, so when we're looking at the submissions for tonight, I want us to be thinking about, and one thing that wasn't mentioned in your list of questions that we should ask Patty, that kind of, especially in this miscellaneous category that we're going to talk about first, is it even a procedure at all? And there are a couple of things in here that are not procedures. They don't belong in a procedure code manual, which is kind of funny. I mean, I actually laughed when I realized that I put these things in there. So we'll say, is it a procedure? Is it a dental procedure? Is it product neutral? Is it provider neutral? Does it impose a business model onto the code that if you don't use this particular business model, it's not a code that's recognized or a procedure that's recognized? So that's how I was thinking about that. And I think with permission of the leadership group, maybe we'll sort of refine our goal number 2 to include that language, but we haven't done it yet. I sort of need a consensus from the group before we do that. But we can go forward with our discussion tonight. So, is there anything else you wanted me to say, Patty?
Yeah, Linda, would you expand a little bit more on what you mean by a business model and how that has somewhat permeated how the CMC has been functioning?
Well, the business models would be a dentist and the owner and the decision maker. Sort of the assumed model, and that the dentist, in every instance, delegates to qualified staff members or qualified employees, put it that way, and then all of the responsibility and liability and accountability goes to the dentist, and little or none belongs to the employee. So that's an employer-employee relationship. But we know that in many states, dental hygienists provide services. They use these codes to describe the services that they're providing, and they don't have a dentist employer. And in some cases, they don't have a dentist collaborator that's overseeing everything for the purpose of professional liability and accountability and all this stuff. Dare I use the word independent? And so we think that any time that the code manual describes procedure in a certain business model, inside of a certain business model, that limits anybody who wants to describe the procedure they're doing using a code if they're not using that model. Anybody have any questions? That kind of hit where you wanted me to hit, Miss Patty Ganji? It's what we've been talking about all along, but there are some instances where I don't know if they necessarily describe it in the ones we're going to talk about tonight, but definitely sort of old school boss, employee does what boss says, stuff like that. Not that if I had a boss right now and my boss wanted me to do certain things, I probably would if I wanted to keep my job, but there's lots of hygienists and others, dental therapists, who are not working in that type of a business model.
Thank you, Linda. That, again, I'm sorry I missed part of it, but I know business model thing, this business model neutrality is a really important thing. This is a code book that is identified by HIPAA as a standard code set for dentistry for not just third-party reimbursements, but also for the electronic health record. So having a provider makes little sense. What happened is the business model of dentistry and of insurance carriers have permeated a process that should be neutral. Is that clearer? Did I get it?
And so at some point we would maybe change our goal number 2 to expand on that that idea, just so that we're clear. What do we mean by consistency and fairness?
Right. Okay, let's move forward. And next slide, Patty. So we're going to go through a little bit of an anatomy of a submission. Some of you, this is going to be you. For other of you, it's going to be, oh, I forgot that. Because every time I look at this, it's the same thing. By the way, can you hear me now? Is it clear?
Yes, a little better,
Yes.
yeah.
Okay, I'm on the phone. So first of all, let's look at who is on the code committee at this point. 5 representatives from ADA, 1 representative from the 9 recognized specialty organizations. As you can read, I'm not going to read them there. 1 representative from AGD, 1 representative from each of the third-party payers, as you can see there, and 1 from ADIA. So that's the list. Now, that's what's important to understand about this is the players. These are the voting members. So there's 21 voting members, and how we connect to, communicate with, and have clarity of purpose with these groups is really important. Next slide. Now, in this submission, I didn't select the submission, and this is one of the ones that we're going to talk about tonight. I'm just going to try and show you a little bit. On this one, Betsy Davis, DMD, as you can see, submitted this code. She did it, though, with the support of the American College of Prosthodontists, who are a voting member on this committee. So that makes the submission a little bit stronger, that they've already gotten a certain level of support. That's why when we, again, are looking at codes submissions to evaluate them, we want to look at not just who submitted them, but who else is also in support of this submission. Next one. Now, coalition building is something that we've talked about. The person who's done the most of that for our group is Kathy Forbes. And Kathy, why don't you talk a bit about the importance of coalition building, as well as progress or where we stand with the various groups, organizations that you have been in contact with.
Sure. At the meeting last March, when we were submitting our codes and whatnot, particularly dealing with prophylaxis definitions, I and some other hygienists talked with the voting member of the American Academy of Pediatric Dentistry, as well as the American Academy of Periodontology, looking to try and form a consensus regarding submissions related to prophy and whatnot. And I reached out to both organizations originally right afterwards, and the AAPD said they were working with the National Association of Dental Plans, which is the NADP, which is a voting member, to define the prophy codes more specifically, and was told that they were leaning toward putting ages back into it. In the meantime, I let them know our group was coming up with something and they were interested in knowing what we were doing. Same thing happened with the AAP when I contacted them. They were working on many perio codes, which we will find out. There's a bunch of them they were working on that had nothing to do with the prophy, but they were interested in what we were doing. So when we submitted our documents to the Code Maintenance Committee on November 1st, we also submitted the entire packet to the AAPD, to the AAP, as well as ADHA. So they had all of our documents of all our rationale, all our photos, everything that we'd done regarding that information. So when the total document of 146 came out right before the holidays. Put it on my calendar that my first available time will be next week on Thursday. I'm going to reach out to each of those again and see if they have any questions, or you know, just reconnect with them, all those organizations, to see if they have any questions, or whether we can come together with some support from them or vice versa. So we'll see where we go from there.
And what that visual is the world spins around via coalitions, okay? And this is where building coalitions is so important. And thinking about that from all of our efforts, we won't be successful if it's only Kathy that's doing that. Now, of course, we have a coalition with ADHA here. Tammy, Tammy, why don't you talk a little bit about the relationship with ADHA and this group and what we're doing together?
Yeah, thanks, Patty. So President Brehrman has asked me to sit on these calls as a liaison for ADHA. And so really my role is to take things back to ADHA, and then historically what has happened is we will look at the things that are presented, whether it's from this group or things that are coming forward in general, and determine which of those submissions align with existing policy that we already have. And so, as Kathy said, we have forwarded those documents. Actually, I'm talking tomorrow with the ADHA leadership about coding, and so more to come on that in terms of, you know, which policies we have that align with the things that are being submitted. As you had indicated earlier, Patty, you know, in the event that there isn't policy, then individuals have an opportunity to submit proposed policy to the ADHA House of Delegates for consideration. And so the deadline for those submissions to the Council on Policy and Bylaws is the last Friday in March. And so I'll kind of pause there, Patty. If there's more that you want me to cover, just let me know.
There will be one, because again, we're gonna throw something out there later that again I'll be able to question, and it might be exactly what we just had, what we discussed there. Okay, moving forward. Next slide, Patty. So the next part of looking at the submissions, again, just to review in general, we want to look: is this a new code? Is this a revised code? Or is this a code that's to be deleted? The next part, next one, Patty. You can see that's the nomenclature. Now, nomenclature is a word that sometimes at first glance people, oh, what's that? It's the name. The name of the code. It's really interesting to watch the coding committee and the way they work. And sometimes they move to shorter names, and sometimes they move to longer names. This name issue, though, has become a real issue because I was just talking with Millie Thaw and Anne Marie De Palma on this, that this is the time of year when every office should have already updated the codes in their software. The software companies all offer it, but what Millie and Marie helped me to understand is not every office does it. And even when they do update, the only part when they put the update in that can't be changed is the code number. Although a lot of times the code number, even in our software systems, are incorrect. Why? Because they dropped the D. And it's not an accurate code, demo code, unless it has the D. In addition, what they do is they shorten the name of the nomenclature for the code. And when they actually shorten the name or change the name, because I've seen where people have gone instead of the gingival inflammation code, the 43446, they call it the gingivitis code. That makes that actually inaccurate in their electronic health records. As I just pointed out, the codes are to populate electronic health records, and that's where even if an office is not involved in third-party payments, they still need to use accurate codes in all records. Next arrow, Patty. This particular code was submitted without a descriptor, which is highly unusual, although it's becoming, I've seen this more happening in the last few years. Next page. Next slide. Now, this one is really interesting, and again, we'll be talking more in depth about a whole suite of codes that go with this. But when we are looking at this stuff to look at who submitted it, there's another part to look at. In this rationale, you can see where the arrow is pointing. And this was actually something that had come up at the code committee when the subcommittee was formulated. So this code is as a result of the ADA Maintenance Committee themselves asking for this code to be created. The reason I say that is because that means it probably has more likelihood of passing. There's lots of different ways codes get through, but when the code committee asks for something to be done, they don't always approve them, but often they do. Move forward. Next slide, Patty. Also to be pointed out that is that this particular code is the rationale for it is technology, technology, technology. And that's important to understand because, next slide, Patty. The next, what has occurred is when in 2012, the code committee with the 21 members as they are formulated now, it was a different committee before 2012. One of the first things they did was determine that codes need to be updated every year. And what you see on here, and this comes from the CDT Companion, is the reason why. Because of the technology, materials that have led to procedures and new stuff, okay? This is why this is an ever ongoing, go back there.
Sorry.
That's why this is an ever ongoing process that as soon as we think we're done with something, we should already be thinking about what's the next one because things have occurred. You know, we submitted our submissions went in on, well, the deadline is November 1st, but that's now 11 months from now. Okay? It just keeps rolling. Next slide. What we will be doing, again, in behaving as if is that what happens at the committee, there are 3 ways people can vote. They can say yay, they can say nay, or they can abstain. So when we get into, as we break down each of these codes that we're going to discuss here today, we're going to ask in the chat box that you put in the code number, as the bottom one shows. So it's the code number, and then just say yay, nay, or abstain. And if you want to give any reasons, any further, great, because that can also add to the body of testimony that we create at a later date. So, you ready to rock and roll? Here we go. Next one, Patty. These are the ones we're going to discuss. If you have your document on your computer or out in front of you, again, it will help. We're going to go through these in the order they're up there. It's empirical for no other reason other than it was easier to organize that way. Next slide. And I want you to all look at Patty Beeson's. I get a lot of mileage out of Patty Beeson's photos and x-rays. She was actually part of the book and she's part of all of it. The first 3 submissions that we're going to look at tonight are on radiographs and images. And so here's the first one. Go ahead. Okay. This is the capture of images. Now, I added the word teledentistry. But what I want you to do is to begin that process of what I just talked about. We see that it was submitted by Tara Manning-Schmidt, and she did this on her own. And this is to add a new code, and it's the intraoral capture of up to 7 images.
Patty, I did an internet search, and the closest I could come to finding is a Dr. Tara Mattingly out of Arizona.
Okay, well, that's one of the things, yeah, we're definitely going to take a look at if we can connect to this person. Go to the next slide.
This is Michelle Gross Panico. I work with Dr. Mattingly on this.
Oh, wow.
So I can potentially answer any questions you want. We thought strategically it would be smarter to have her submit it because she's a dentist and a member of the Dental Association. So we thought strategically it'd be best for her, and she wanted to take the initiative to go ahead and submit it. But her and I have been discussing it for about 3 years, and finally we decided to do it.
And this is where I was going to suggest, first of all, we wanted to definitely track her down. So thank you. That was good to know. And one of the things she missed then is putting her credentials on here. Or they took her credentials off because I don't see DDS, I see none of that on her name. Because that's how, and again, this is part of the gamemanship of this whole process. So with her name, if she was identified, because you'll see other ones that they identify it, and that's the way they fill them out. Is that right, Kathy?
Yes, yeah. Having the credentials, whether it should or shouldn't make a difference, does definitely have an impact on that first impression of who is submitting the code.
Yes, yes. So the first one refers to 7 or less images. This is for the capture of 8 or more. Go to the next page. Next slide, Daddy. And you know what, Michelle, since you're here, go for it. Why don't you explain this to us?
Well, what we're attempting to accomplish is to help guide the implementation of the affiliated practice dental hygiene model in the state of Arizona. We have affiliated practice dental hygiene models that are out in the community at non-traditional locations and settings. And they're taking images and then sharing those images through teledentistry to have their affiliated practice dentist read them and then put notes in the chart. We recognized early on in setting up some of these models throughout Arizona that the billing mechanism was a little strained with this type of setup because the current codes that exist require that before there's a submission of a claim, the radiograph the image needs to be taken, captured, and read. So we were having the dental hygienist as a direct access to care provider doing the capturing, and then the dentist through teledentistry doing the reading or diagnosing off of the image. So it was really happening in two different steps. So what we had to do to kind of navigate around that is that we would have the hygienist capture and then the dentist read and then the dentist submit the claim and then the dentist do a split on whatever reimbursement was. There was then like a business agreement or memorandum of understanding that was drawn up, and there was a divide or a split. They would say, okay, 60% of that reimbursement goes to hygienist and 40% goes to dentist, or somewhere 80-20. So we kind of figured out a way around it, but we knew that eventually this had to be addressed, and what we were hoping is that we could develop a few codes that could potentially be used for for this type of model where you have direct access to care and teledentistry. So we didn't want to create all of the codes all over again, so just decided on a certain set of codes that would minimize how many new codes would have to be made. So we kind of kept in mind that sometimes there's 4 bite wings, sometimes there's 7, sometimes there's a full mouth series, and so that's why you'll see the grouping of the different numbering, like under, above less than 7 images or above 8 images. And we did take a look at some of the reimbursement fees and kind of were strategic about where that breakdown would occur. So that's kind of the intention behind it. I don't know that I necessarily need to read all that to you. That's in front of you. You all can read it, but that's where we were going at with it, so that direct access to care dental hygienists can, in fact, submit a claim and get reimbursed for capturing an image. And then the dentist can, after reading the image, submit a claim and be reimbursed for reading, rather than that both having capture and reading having to happen, and then one claim being submitted by the dentist only.
Patty?
Thank you, Michelle. That was really enlightening. Yeah, who's that?
Patty?
Yeah?
This is Linda. I'm getting some scuffling feedback.
Okay, who's opening a paper bag?
So one of the questions that I have, I think this is really good, but if we applied our provider neutral criteria to this submission, I think the rationale might change a little bit. But I think it's important to, I like the idea of identifying the person, the provider who's actually capturing the images, and then the provider who's interpreting them. So it seems like and then the method by which they do that, by which they do that consultation with each other, and using teledentistry. I totally get that, but this can be applied to 2 dentists talking to each other about a case too, or a dental therapist, or a number of different providers. So some of the rationale, and I don't recall whether or not that language winds up in the descriptor about the dentist interpreting and all that kind of stuff, but just
the rationale, let me explain that in a second. The rationale does not end up in the code itself, but in a very interesting move in CDT Companion, the rationale has ended up over there as explanations as to how codes are, and that's again, that has the identification as being published by ADA. And so there's the CDT book and there's the CDT Companion. And the first I noticed it was this year was the glucometer reading code that we have for 2019. The rationale given was the rationale that was taken directly from here, from this type of a thing. So this rationale, how they're written, is very, very important. Yes, it's what the initial decision is made on, but it's also going farther than that at this time.
Well, think of another issue is whether or not a medical doctor and a dentist or a dental hygienist or a therapist or someone in a dental environment corresponds or consults with a medical personnel on a shared patient. So this could be used for that too.
Absolutely. And you can see in this rationale, she does mention 40 states having the direct access dental hygienist. And she does also discuss the needs to recognize that this is the current situation with the use of teledentistry. She mentions additional codes are needed to kind of help us navigate the landscape of teledentistry. But you're right, there's other potential uses of it. I think in the most practical, immediate use, we saw a need for it with the direct access to care dental hygienist. In the future, in Arizona just got dental therapy, so yeah, I could see where it would be useful in dental therapy also. However, our dental therapists in Arizona will be able to capture and read or diagnose. So potentially in Arizona, we wouldn't have such an indication for dental therapy. But nevertheless, I agree with you, there's other implications.
There's other applications, including the one I thought of immediately because I just answered a question on it. I had somebody contact me that asked me that they heard a speaker that said, well, you know, I work under general supervision and I take the radiographs, but it's the reading of the radiographs is when the submission goes. So if the hygienist takes the radiographs under general supervision and they're not read for 2 days, what's the accurate date of service? And this is where it's problematic the way it's been now. And this is an opportunity, and that's where having one code for a capture and another one for a reading has an application for every practice setting that we're in. Because right now we don't have accurate record keeping if it's charted or it's recorded on the day that it's taken. That's not accurate. If it's recorded only on the day that the doctor reads it, that's not accurate either. So this has a lot of ramifications farther than I think teledentistry only.
Patty, this is Kathy. If I might intercede, Michelle, I'm hoping that either you or Dr. Mattingly will be at the CMC meeting, because when these codes are introduced, they're going to ask if there is someone there representing this code to speak to it. And from experience, the first time I submitted a code, I did not go. And it kind of went whizzing by because there was no one who was the essential maker of the motion to speak to it. And the next time I made sure I was there, and it did get through with modifications. So I don't know if you or Dr. Mattingly was planning on being there, but I strongly suggest that.
I did not have any intention on attending, but in light of the information that you just shared, I could certainly look into it. I can Google and try to figure out date, time, location. What is it particularly called, or exactly called? CMC, you said?
Code Maintenance Committee.
If that was what I had up on the screen before, it's the March 5th, 14th, and 15th. The dates that I mentioned before. That's what that is. And also, you may want to consider inviting Dr. Manning to join us here, because then, we as a body would go and, we would put our VA co-signer on there, so to speak, and then somebody from our committee is always in attendance there. So that's for the future, but that's also for anybody else here thinking about something like this. Do we have any other comments on this particular item? Nothing? Anything in the chat box, Jamie?
Patty, I have a question. This is Linda. Are there any other codes now about teledentistry? I have the book here, but I figured somebody might know. Is there anything in the code manual right now about teledentistry?
Excuse me, I wrote an entire book about it. You're not from. Who's speaking? Who asked the question?
Linda.
Me, Linda Jorgensen.
Cindy Jorgensen. I wrote the book with Cindy Purdy. You don't know this? Yeah, there's actually 2 codes this year that came into being for the first time, and for CVT 2020, actually for 2018. And we're going to actually look at those 2 codes because those 2 codes, well, if we have time, because those 2 codes are actually submitted for revision this year.
For not knowing that. I know you wrote the book,
okay.
But
Yeah, the ADA has the ADA has guidelines for using those 2 codes. It's about 10 pages long. You can go on the ADA website and pull it up.
Thank you.
Sure.
Yep. Okay, next slide.
There's nothing else in the Dropbox.
Okay, we're ready to vote, everybody? Now there should be things in the chat box. Are you in favor of these? You're going to say yay, nay, abstain. So everybody, please put in your vote. If you could put in the numbers of the codes, because later on when we go to pull this back out, it'll make it easier. The submissions, they're not codes yet until they get passed.
Patty, it's Noelle Paschke. I know you asked me to track these. They're flying by so fast, I can't keep up with them. So
That's okay. That's okay. You know what I'm going to do is if I can send you this, actually, Patty, I'll have to send it to you. Patty Beeson, you'll have on your computer not only the recording, you'll have the chat log. And if we can get that chat log to Noelle, then Noelle, you can pull it and those numbers together. Okay.
Okay.
But I see people voting on 33 and 34, and is that what you wanted to happen?
Yes, because we're voting on 2.
I put a little milk in my.
Because one is for less than 7 images, and one is greater 8 or greater.
Okay,
right?
just
Michelle?
verifying.
You sure this isn't just frozen? The one he said was bad.
Somebody's cooking something.
Okay.
Next
So
one.
everybody vote that there is, and you know, I see, Tasha, you put to see provider neutral language. The provider neutral language would be added, that would be in the rationale. The code itself and the way the code's, Patty, go back a couple slides to show the code itself as it's submitted. See, it's intraoral capture of 8 images or more. Huh? And Sandra, next time put the numbers in, because again, we're going to need to coordinate these later. So, thank you. Thank you. Okay, moving forward. Next one. Okay, the next is for intraoral full mouth series, child. And again, hopefully you've all have these in front of you. I'm not going to read the descriptor to you. Go to the next page, Patty. And this is interesting. Well, let's go back one. This looks like it's a from a dentist, and what he did is his and Michelle, this is the other thing that he put his own practice. Now, I don't know, Maxon Dental, is that a big group? Is that a small group? I don't know. But it's interesting how people fill this stuff out. And this is a full mouth series for a child. What's interesting, go to the next one, the definition of a child is not defined anywhere in any of this language. And this is about fees. I don't know, let's open this up to discussion.
Hey, Patty, it's
Hello.
Connie.
Yes.
I think that this is going to lead to nothing but trouble. Just like we're having trouble deciding about Profi codes, someone's going to interpret this, and just like you said, there's nothing in here about an age, and I don't understand really the rationale. What's the need for it? I don't know. I'm confused about it, but I think the biggest problem is going to be that there isn't anything mentioned about the age of the patient they're talking about.
Thank you, Connie. Any other comments?
Patty, it's Evelyn. It seems
Hi,
like they're.
Ev.
Hi, Patty. Sorry, I missed your other one. Anyway, it seems like they're trying to do this because when you first had the other slide up, it's talking about that people are charging the same amount for taking a full mouth on children that they are an adult, even though there's fewer teeth. So I think that maybe his rationale behind this is that if it's a child, and he again should put an age in there up to a certain age, and how much, is it deciduous dentition? Is it mixed dentition? Whatever, that they charge a lower fee. And so he wants a different code for a child. That's what I'm getting out of this. But it's like you said, it's not very well written, the explanation.
So this is Noel Paschke.
One of the parameters is it clear?
And this is really talking about fees, and the doctor can decide on what fees they want to charge. It's not so much, procedure. There's already procedure codes that are in existence, and so it's a matter of adjusting fees, not so much adjusting code.
Right, that's how I got that too. I agree with you.
Lisa, what are you saying in the chat box about a Panorex?
So I just see that it was a fee thing too. I'm wondering, can you hear me? I'm just wondering if there's a number of x-rays in full mouth coding. Does it say there's a specific number?
Yes.
I'm not understanding why because you could take a Panorex, why can't we take a full mouth? Is it age-based, or is there a number of x-rays limited in full mouth? Does anybody know that?
It is not. Codes are there's nothing in the language of the codes for age-based for radiographs. There is, I'm looking it up as we talk, unless Kathy can get to it faster.
I'm trying.
I think there is a number of images. Yeah.
Janet says it says 18 films.
Yeah. Patty, the gold standard for a full series is always an adult full series. And so that assumes 18 images, and it assumes like an average size of the entire.
But we've got to go by what the language of the codes is. And the language of the codes
consists of 14 to 22 PAs.
Okay. So
thank you, Kathy.
You're welcome.
I agree that there's no specific code for pediatric, like a pediatric sized arch, but the idea of the idea of capturing everything that's in that arch is going to be different. That the number of films that you need to capture a smaller arch is different from a full-sized arch. So even if there are no teeth in the arch, there is at least the potential. I get it why they're asking for this. However, I think there are other ways of getting at coding the procedure of capturing an image of a pediatric patient, whether it's through PANS or a series of periapicals or even occlusal films. You can use occlusal films to get good images of a small arch. I don't know. I'm not sure that it's necessary. That's my 2 cents.
Any other discussion? Okay. Are we ready to vote? Patty, go to the next slide. Remember, put the code number, it helps. In
the inventory number.
The inventory number, yes. Thank you.
Well, but the inventory number is not showing up on the screen, so it's hard to.
Yeah, it is at the top.
Yes,
it says chat box
Yes, it is.
35.
It says chat box 35.
Okay, I'm sorry. I do see that.
That's okay.
That's okay. We're looking at lots of things.
Well, I'm thinking inventory number, chat box, blah,
It's
blah.
for the chat box, yeah.
Okay. Look,
okay.
Give me a job to do, I got to do it.
And do it
I don't want to mess it up or I'll be in big trouble. I feel for you, Noel.
Slide. Kathy, I am going to ask you to take over the lead of this one and probably lead from this point because I got to move to my gate.
Move to your gate.
I'll be listening. I need to move to my gate. All right.
Okay, I will do my best.
Okay.
Okay, inventory number 37. There's quite a number of codes submitted by Alan Wong, as representing the American Academy of Cardiology in Canberra. And in fact, there's a number in this bunch, and we'll be talking about some others down the road. But this is one, when we take a look at it, if you go to the next slide, Patty, he kind of flip-flopped nomenclature and descriptor. And even then, if it should be flip-flop, the descriptor is way too long. So I'm not quite sure where he was going with it. Salivary assessment. For those of you out there that deal more with salivary flow assessments, do you have any comments on this?
Kathy?
Yes?
This is Linda Jorgensen. I have to confess I don't deal with it, but I know a little bit about it. There are two issues that come with salivary testing. One is flow assessment, and then the other is quality. So it's like the amount of saliva, is it adequate to function, as buffers and moisturizing and all that kind of stuff. But then there's also the quality of the saliva. So what's in it, and is it doing what? Anyway, so I think this particular submission misses an important opportunity to talk about not just salivary flow assessment, because that's so limited, but also when you do salivary testing, and I'm hoping somebody's on this call who actually does that or has done that. I'm not that person, but I know that the other important thing to think about with salivary testing is the quality of the saliva. What's in it?
Patty, let's move it to the next slide, because it goes into some of the rationale that Linda's been talking about the protective qualities and whatnot. I am, since I don't deal with this, I can see a need for something. I'm just not sure this was presented well enough. In fact, the next slide actually goes into the technical description of what he's talking about. So anybody else have any?
Well, I've worked a great deal. I've worked with saliva testing, and the main issue that I have with this is not written at all as a code. This is written as a C course. This is written as a educational document, and not actually that well written as an educational document in some ways. So I think this is where, again, we might have opportunity as a group to join with the Canberra Coalition. I know I'm a member myself, and as I mentioned, their meeting is a couple of days. I think it's the Wednesday or something before the Codes Committee, but I think we have opportunity here because I think this would be within the realm of something important for us to participate. But this whole thing, I just can't see this thing flying in the way certainly the way it's written now.
Patty and Kathy, this is Linda again. There is a code D0418.
There is a code, right?
It's an analysis of saliva sample. And then there's another one, 0417, collection and preparation of saliva sample for laboratory testing. So there's two codes.
Those are laboratory tests, and I think that these are chairside tests is what they're trying to get to here.
Right. Okay.
But see, that's, again, this is the one that I referenced before. Where it says clear, and the answer is it is not clear at all. Okay, good guys, keep going.
So I think, in terms of voting, anybody have any other comments?
It's very difficult to get paid on those codes.
And I understand. And yes, I agree, from the dental standpoint, and that's why but when we're considering procedures, we need to consider not whether they're paid or not, but is it the actual procedure? I I know we need to be mindful of budgets and reimbursement, but at least being able to identify the procedure itself, and we need to be clear about that.
Correct. But however, if you submit it under a medical code and submit it under the patient's medical insurance,
oh, absolutely,
then you do get reimbursed without a problem.
Right. And I think that's looking way down the road. That's exactly where we're going. Many of our dental codes can be submitted under medical, but it's teaching business people and whatnot to do medical claims and diagnostic codes and procedure codes within the medical realm. So, yeah, that's the big picture we need to be doing. But definitely understanding a lot of these can go either way. So let's go ahead and move to voting yay or nay on this. Someone sure got a cute little voice coming in the background.
That's Linda Gurwitowski driving back from the ski hill. So I've been in and out of this meeting, depending where we've been.
Okay, let's move on to the next one. People are voting. This next one is one we have submitted. And Alicia, would you mind, so that I'm not doing a lot of talking, talk about this particular code that we developed within our group?
Oh boy, okay, I'll try.
Yeah. Next slide, Patty.
Okay.
There we go.
Let's see. Counseling related to non-therapeutic use of drugs for the control and prevention of oral disease. Sorry, it's been a while since I read this. I think this we intended to take out tobacco specific and just include counseling on a lot of issues that we do on other things as well, like now with marijuana, even if we start talking about opioids, things like that. So it's really basic and simple, just to open up what we can counsel patients on in our scopes of practice. How's that, Kathy?
That's awesome. Thank you. If you want to move to the next slide, Patty gives a little bit of the detail, and we actually pulled up the ADA has many policies related to this so that they could, you know, we like to support these kinds of things with things they've already developed. Kind of. So, okay. Yep, keep going. There you go. Any questions?
This really opened up the dental hygienist to anything addictive or potentially abused by general population.
Mm-hmm. Or any dental provider who may be, you know, providing this kind of counseling service. So, if there's no objection, let's go ahead and vote.
Mm-hmm. I can't tell you how many times I've peekaboo.
Peekaboo. Okay. Moving on to 134. Patty, are you still on the line?
I am still on the line.
Can you explain about Scott Davis and the American Association of Endo and Biomimetric?
Oh, yeah.
That particular code.
Okay. The Academy of Biometric Dentistry has, at least for the last 3, maybe 4 years, have submitted a suite of codes on their philosophy of care. And they have gotten not too far at all with it. And they
Linda,
also,
can you mute yourself, please? Linda, thank you.
I'm Linda Gurwitowski from Colorado.
Linda, can you mute your phone?
Please mute your phone.
Picking up the noise.
Thank you.
Anyway, so what happened is they have gone down in flames every time. And part of it is a big philosophical difference between what the dentists from the Biomedic Association believe and what has been the long position of ADA. Well, it appears to me that what's happening here is they're doing an end around. What do I mean by that? The Bears just lost. Oh, well, anyway, the football term. And what they're doing is, rather than going directly at ADA, they've joined with the American Association of Endodontics. And what they've done is this takes this biomedic, which there's already people on they see that it's like, oh, those guys again. Well, they've now associated with somebody that is a member. So they already have somebody from the CMC that's supporting this particular submission. Now, next slide, Patty. I'm not looking at this. I'm doing this by memory.
I know.
As you can see, it's for rubber dam placement.
Rubber dam placement,
and
right.
Rubber dam placement, and there is no descriptor. If you go to the next page, Kathy, you're going to have to take this over.
Yep.
I'll get my slides
It
up.
says it cannot be considered unbundling because there is not a descriptor what identifies rubber dam placement. And even if there was a descriptor which made rubber dam placement a part of the procedure, there would be no documented evidence that it was done, only by assumption. Talks further about still necessary in order to maintain, quote, best practices, end quote. Therefore, it should therefore be considered not a technique, but a procedure, which is really interesting that they would pull this up. If you go to the next slide, what's even more best practices, yes, that word is coming up more and more.
Right.
I mean, even my husband who's in IT and he helps implement Microsoft programs, the best practices of Microsoft are, that they brought that terminology forward and it's now running over into dentistry. If you go to the next slide, what's even, oops.
Oh, God. Oh.
What happened to there should be a slide before that. Woo.
Nope.
Ah.
What she's talking,
Okay.
what Patty's talking about, if I remember correctly, we talked about this afternoon. It's about the best practices and the terminology, and that this is part of learning the language that we have in our Insurance Navigator course. And that you get this is the best place to get the definition of best practices, as well as all the other definitions. Go to the ADA, and they have a glossary of all their clinical and administrative terms. And that's what she was bringing in here because in this code, that's what they're bringing forward. Okay.
And if you go to the next slide, it's actually the definition.
Go back a second. Go back a second.
Sorry.
Let me talk a little bit about where the Insurance Navigator is. The Dental Codeology Insurance Navigator method actually is now the name of it. The reason is that as I've taken the curriculum that I bought last year and I was going to rebrand it, what we've decided is that we need so much more specific information other than just how insurance works. We need to understand coding. We understand so much more than that. We do start with terminology as the first part of it because until we understand the basic language and agree on a basic language, we have a really hard time getting anywhere. So that's why in the Insurance Navigator, the very first lesson is on terminology. Now what the next slide is it shows the ADA glossary. When it comes to the CDT book and all things in this arena, that's what they fall back to. Now, other associations and other groups will bring forward definitions that sometimes are the same and sometimes they're different. And sometimes it's negotiation of those different definitions. I know when we looked at prophylaxis codes in that committee, they looked for as many definitions of prophylaxis as they could find from all venues. But when it comes down to it, if the code committee is going to do a fallback of this is the one that we want, is they're going to look at the ADA one. So it's important that we are aware of this ADA glossary of terms. Now, the next slide, I don't know what it looks like.
It's the unbundling of procedures definition, which was developed by the ADA in terms of pulling procedures apart. They
Unbundling,
have,
yeah. But
yeah,
Kathy,
unbundling.
go ahead, read that specific.
It says the separating of dental procedures into component parts, with each part having a charge so that the cumulative charge of the components is greater than the total charge to patients who are not beneficiaries of dental benefit plan for the same procedure. The example I give when I'm doing courses is the definition of peri-maintenance. Within that definition is actually procedures which relate to an adult prophylaxis. And what we see many practices doing is, oh, their plan doesn't pay for a perio maintenance. Since adult prophy is part of it, we will unbundle adult prophy and we'll only bill that because we know we'll get money for that. And that's unbundling. And it's not only wrong, it's against the law. Legally, you cannot unbundle procedures. So that's,
and this is where, but this is also where there is a differentiation between the medical world and the dental world. As a matter of fact, Kendra, I'm going to throw you in here. Are you there, Kendra? Kendra has been specializing in medical coding for the last period of time, and she's been very successful in helping more oral health care being covered through someone's medical plan. And Kendra, in the medical plans, is everything unbundled?
No. And it's different per insurance company as well. They'll tell you what
For
they want you
insurance
to
company.
do.
But as far as the coding, are there not codes for a huge variety of things versus a global one that we see in dentistry?
Oh, for sure. And that's why there's like 65,000 of them versus what we have in dentistry.
That's where I want you to go. Yeah, there's 65,000 medical code versus our less than 1,000 that we have in dental. So
and that's why we can't. That's why we can't call it cross coding, because there is no 1-to-1 ratio.
Nope.
Right. Right. And this is where there is, even within the oral health community, are we more medical or are we dental? And that's where, again, that concept of medically necessary coding comes in. We need to change the thinking around this. This is a little bit of an attempt at that in a way. So go ahead, Kathy.
Yeah. So with that, understanding terminology is going to be really important for our profession to be on the same page. Go to the next slide. One of the things, Tammy, that we were, when looking at all this and trying to look through the ADHA policy manual, is ADHA has not defined best practices. So in terms of planning for, you know, the next session in June, that might be something the board might want to take a look at and see if we can come up, ADHA, with some kind of language for that.
Well, I don't actually know if best practices has a definition in ADHA manual or not. I know ADA, that glossary does not. So this might be the opportunity. Yep. And of course, it wouldn't be Tammy that brings that. It would be
right. Tammy, do it all.
Tammy, you do it all. You bring those kids to Tammy.
Yeah, I was just going to chime in there too, Patty, because, you know, at this point, the announcement's gone out. So if this group wanted to propose a definition, that would be the process like you did previously for, I think it was a laser code.
Right.
It
And
didn't
you
come
would
from
have it
from a member of this committee.
last Friday in March deadline.
Yeah.
Right. Okay. Let me ask you a question for clarification. Can our committee bring a proposal to the ADHA?
Tammy, this is Jill.
Yes, Patty, I can send you the criteria on who can submit, and then you can put it in the Dropbox if that would be helpful.
Okay,
Yeah,
great,
because
great.
it will come
So
through,
what I hear
you know,
saying then, it's not, so ADHA
Tammy?
does not have a closed process for submissions.
Right.
No, but there's a process
Right.
for it to come. There's a process that's defined for who can submit. And I can forward that to you, Patty, so that I'll send you the letter that actually goes out from CPB.
Okay. Okay. Yeah. And again, I'm aware of it. I just wanted to make as many people possible here aware of that there is a process, but it's not
right because it didn't come from the committee last time. But I think the committee work may have been referenced in the justification. I don't quite recall.
It was Michelle Race who brought it forward from New York, and she's a committee member, and she brought it as a delegate from New York.
That's correct. Yep.
Jill, you've been wanting to try and get in there?
I've been trying to get in. Yes, Tammy and Patty, there is a definition in the operational guide of it. It's not in the glossary, but it's the ADHA operational guide. It lists best practices and it gives their definition or solution to it, so we could lean off of that. It has to go before. I think it has to go before maybe a submission of somebody coming before a delegate or something of that nature from an association coming before to submit a definition for best practices. But there is something in the operational guide on best practices. Does that make sense?
Okay. If we move to the next slide, the wrapping up about this dam, this makes an interesting question. It says, we all laugh. If rubber dam placement is considered standard of care and or best practices, then why do we even need a majority vote other than agreeing with the stated protocols of the AAE and the endodontic rep on the CMC? All that should then be required of other voting members is to concur with the specialist and vote in the affirmative.
No.
I'm going to stick that phrase on my wall for the next time I submit codes. Anyway,
I think we're ready to vote. Right?
I think we're ready to vote on this.
Right, because they're trying to play politics at the end, but then they did a big no squeak at the end. Yeah. So.
Has a code.
I just want to be there to watch this testimony being given.
Probably be on Friday because it's, later in the numbers, but
right. I'll bring my popcorn.
Okay, we're moving along here. So this next one, box 138, has to do with that an ADA trustee is submitting it. Now the question when I first looked at this was, does that mean ADA is submitting it, or is it just the trustee or the trustee representing the 5th district? We don't know. So I have no idea where this comes from. If you go to the next slide, it's donated dental treatment and services per visit. Patty, you had some insight in that?
I don't have any insight other than looking at it and reading into it myself. So go ahead.
Yes, your insight.
Yeah, I have opinions. What's interesting, I think, about this code really goes on to the next slide. You had to go to the next slide because if you look at the rationale that they said, oh, you did, I didn't, I'm sorry. I can't see what you're doing.
Yeah.
What's interesting is what I see this as is something that I've been preaching for a long time, that the codes represent something more than for third-party reimbursement, and how they report it. They represent powerful metrics. As you can see in that rationale, they talk about the numbers that are collected by the Center for Medicare and Medicaid, yet we're not getting proper credit for the volunteer work we're doing. Of course, this is all written very dentist-centric, and what is the most important part to me when I look at it is the first line of the third paragraph, establishing a standard code will establish a powerful data collection tool. That's the metrics part. And that's where the whole thing of codes, and again, this is where I look at it. If this came from ADA, it came from a district. Does anybody happen to know who the 5th district is, what area of the country that is from ADA?
Patty, I have a question. The only people who keep the data are the carriers or the Centers for Medicare and Medicaid. And it's not necessarily Medicare and Medicaid patients that they're donating care for. So who's going to collect the data on the other patients?
And that's a really good question, because right now there is no central place for data collection. At this point, that's why even when I look at statistics and they say this percentage of this and that percentage of that, The only way that we have that data is through a third-party carriers and somebody that might be doing a study. But actually having complete data, it doesn't really exist.
No.
Do we really know how many of XD things are done in practices across the country? No, we really don't.
I can't
how many
believe that the insurance carriers would want to start keeping track of data of donated services.
I get that, but remember, Kathy, this is not for insurance companies. This is for codes. The codes are for electronic health records. And electronic health records have the potential of that data being collected. Yet, this is the catch-22, which comes first.
Yeah. Okay.
This is Noelle Paschke. I actually think it's a great idea. And here's why, is that it also would tie into potential for research funding. The collection of this data and the metrics, I think, would also give an indication of the severity and the breadth of dental disease in this country. And so I really think that it would be great to have this data and have it memorialized and having a code for it.
Noelle, the thing that concerns me is throughout the whole rationale, they're only talking about dentists doing it. The dentist would enter the code, the dentist usual fee, the dentist.
I see what you're saying.
And it wouldn't be the therapists or the hygienists or the assistants going into schools or anybody else. It's a very, and the nomenclature doesn't say it's only dentists. The descriptor doesn't, but the rationale might say it's only a dentist code. I mean, there could be,
Well, I think at the hearing, since everything does get say at the hearing, that we be prepared to talk about the number of different dental providers and see if someone on the committee would be willing to make a very strong amendment or language that would clarify that, which we know as from last year's hearing, they're not necessarily going to do that. They're just going to,
But there isn't a language that really needs to be changed, because even in the process of, again, these rationales go away. Like I said, I saw them used this time in a book later, but they are not actually part of the coding book in the future. So what I've not seen is, even though when there's different argumentation and different ways things are decided, that rationale goes away. And Tammy, the legislative process for ADHA, it's the same thing, right?
Sorry,
Tammy?
Patty, I had to get off of mute. What's your question again about the process?
My question was, the process is the same as we do at ADHA. When something is submitted to ADHA, even if the argumentation has changed and the rationale and the decision-making has changed, ultimately the only thing that ever shows in publication is the final decision, correct?
In the minutes, yes.
I'm not talking to the minutes. I'm actually talking to the policy book. In the policy book.
Yes. The policy itself, the justification doesn't, who submitted it, none of that, correct.
Right.
Maybe we could figure out which hygienists that could be part of our group that are in the 5th district could contact a trustee and get some more information.
Well, I think this goes back to the general thing that we were talking about before, way back in the beginning, about it being neutral, provider neutral. And this rationale isn't provider neutral any more than we go back to the codes on radiographs, that was not written provider neutral either. And those parameters that we said they should be provider neutral, those are our parameters. I don't know, we made those up.
Yep.
But it makes sense from a business. There's a business part of it, but there's a, what is who's the code book for? What does it represent? And it's not supposed to be something for a particular business model.
Yep. So. Okay. So we're ready to, let's see, different thinking.
There is something we want to point out on this slide, Kathy, because again, on the bottom, there's a really important statement that's made in that final paragraph. And that is, while 5th District Trustee District respectfully defers to the expertise of the members of the CMC in promulgating the way to uniformly track donated care, one way we believe is CDT. So what they did is they said, hey, we leave it to you guys, and they stroke their egos. And, I'm not trying to be crass here. I'm just trying to say the real politics of how this stuff works.
The last
this
paragraph.
is what they've done. So.
Okay. We ready to vote? Let's go to the next slide and vote. Okie doke. We've gone past our hour and a half here. Let's see where we're at. Inventory 139.
And I think let's ask the group if they want to move forward and release this. Because I'm going to suggest that the last two, which are on teledentistry, get moved to a different evening for two reasons. One of them is I am definitely not a place where I could talk as readily as I'd like. And secondly, Cindy Purdy has some particular expertise on that, and she's not here. She couldn't attend tonight. So we can either stop now, or we can do these last two and just table the teledentistry. So what do you as a group want to do?
Do the last two and table the 145, 146, because we've got a lot more work to do when you look at the rest of the list.
Right. And I think these next two should go pretty quickly, personally. Okay, moving forward. 139 is a facility fee. Now, I don't know who Dr. John Robertson is, but if we take a look at, get on the right page here. Sorry about that. I've got too many pages. If we go to the next page, dentistry is long overdue. That many dental offices receive hospital accreditation, those kinds of entities. I know the periodontist I worked for years ago was also designated as a surgery site for dental procedures. And I think this is allowing for those who have a dedicated dental office that is accredited, that it's a surgical facility, could bill for a facility fee. So that's it. Best practices who achieve accreditation would present for that. So any comments?
Kathy, this is Linda Jorgensen. This is not a procedure.
True.
At all. So a dental practice is always free to charge a facilities fee if that fits with their business model. They want to do that because they feel like they've gone over and above like standard. They've met some accreditation standards, and I don't know, they're the highest tech place on the block, and they want to charge for it. They can always do that, but I don't think it. For me, this doesn't rise to codable. So I would, it's not a procedure, it doesn't belong in a procedure manual at all.
The only thing I might bring up is there is a section in adjunctive called professional visits for house or extended care facilities or hospital or ambulatory surgical centers. So there might be precedent set
but that is the procedure. That's a billing for a procedure, was that the patient visits. And you're doing something with, I suppose there's already a code then for that, right?
The hospital one says care provided outside the dentist's office to a patient who's in a hospital or ambulatory surgical center. So I think my assumption is they're looking for one where they're dedicated themselves, they're the center itself. So that, I would personally need more clarification of that, because you're right, a facility fee is not a procedure, but then looking back at the adjunctive services, maybe that would be, I don't know.
The last line on the rationale says dental insurance companies will more than likely not cover the CDT code dedicated to facility, but at least there should exist a code for dental offices to submit a claim. Again, I see this as somebody trying to create something with metrics and accountability and that sort of thing. And again, this is where there's canceled appointment fee. Code. There's a missed appointment code. There's a taxes, charging sales tax code that are not procedures. And this is where the committee has traditionally come down negatively, but there are people that have gone to the committee and said that they need it for this reason, that reason, whatever, within their particular states. In my opinion, it appears that this is somebody that is trying to move something into looking at a oral health practice as a facility in addition and above, and the standards you have to hold for your facility above and beyond what the individual practitioners also hold. But, you know, whether or not there's.
I think it's an attempt. I think it's an attempt for revenue generation.
Yep.
No.
Just saying.
Okay, let's go ahead and vote. I think we know what's
Oh,
going
there's
with
more.
this. Oh, there's more. There may be in, okay.
Okay. Move on.
Okay. Everybody voting. One. Final one. This particular 140 is Dr. Joe Dilbert. He represents for the Delta Dental Plans. So we already, it's dental case management for special needs. And if we go to the next slide, they a year or two ago did create dental case management for these particular areas. So it looks like the Delta Dental Plans are looking that this might be a code they would like to see introduced. If we go to the rationale, currently no method for identifying services provided to patients with special needs. Non-clinical administrative code, which is what these other four are, would facilitate processing of claims and documentation. And one example is the state of Wisconsin. So Linda, maybe you can speak to that. Do you know much about this one?
Oh, no. I don't.
No, let's go to the next slide because Linda, it talks about some specific legislation and the budget, Wisconsin legislature budget. If you go there, I don't know if you have any.
I've got it on the slide.
Yeah. So
or, you know, Tammy, you're Wisconsin too. If you have any.
To be honest,
information.
I think that the four codes that you showed in a previous slide, Kathy, do cover, even though it's not specifically stated, special needs patients. If you're at that point where you're going to have to do a whole lot of coordination with another provider or like a benefits manager or something like that because it's so complex, it's because your patient has special needs.
Right.
And so when you impose this kind of a limitation on it, okay, now we have to describe, we have to have a code for special needs patients, then you require another diagnosis. Like what are the special needs that need?
Well, I'm looking at what that enhanced reimbursement, it looks like what they're trying to do because the DHS is providing reimbursements to facilities that provide 90% of their services to individuals with cognitive and physical disabilities. So my assumption is they want to be able to have a code to that so when they can be reimbursed for these services. Now, whether it's only limiting to Wisconsin, obviously Delta Dental, probably in Wisconsin, is the one that wants to see this go through so they can have their dentists paid. That's my reading of this.
And the cognitive and physical disabilities, I'm looking at the line, it says as determined by the department, not the provider. So the patient has already been described as having a disability of some type that's going to require some special care. Okay. All right. Yeah, that's.
There is some precedent, Kathy, for what you just said. The case management codes, as they stand now, and it's probably actually about 3 or 4 years ago now that this came up, and those were specifically brought by California Public Health. And it was about within their realm that they needed in order to get reimbursement under their different programs in California. They needed case management codes. They needed to have like the one that shows the appointment compliance and things like that. Those were also, there is a precedence for having this type of an identification that might only apply in one state at a given time.
Okay. All right. If anybody has no further questions, we'll go ahead and vote. Okay, and I think the rest of the slides have to do with the teledentistry codes that we're going to table until both
That's
Cindy
82.
and Pat. Pardon me?
Jump to 82, and I'll do
Jump
the
to
close.
82. Oh, okay.
Okay. So thank you, everyone. We made it through this first one. We're going to try and get the submissions, the inventory to you a little bit sooner, so you have a little more time to look at this. We really do want to hear from the rest of you. There's some of us, yeah, we've been at it. We apologize if it's dominated. We want this to be an open conversation with everybody participating as much as possible. So thank you. Thanks for hanging in here, especially late on a Sunday night. Next slide, I want to remind you, in the invitation for the mastermind is on Monday the 14th. We'll go out on Tuesday. Look for that. Also put on your calendar that our next one of these is on January 20th. And you will get the reminder for that. Until then, text me, email, Facebook to me, instant messenger, however you want to get a hold of me. I'm more than happy to help. And the future is ours to create. Because what we're doing in this group is not waiting for the future to happen, but we're creating the future. And we are up to it. So thank you, everybody. Thanks for being here, and thanks for your participation.
Thank you, Patty, and everybody. I like your picture. Beautiful.
Yep. Bye-bye. Have a safe trip, Patty.
And thanks, everybody that participated and contributed to this. All right. Good night now.
Good night.
Good night.
Thanks, Patty. Good night.